behind the scenes ده مجرد الحاجات اللي احنا بنشوفها حوالين الجراحة. يعني احنا عايزين دلوقتي نوصل لكم teaching experience كل ما هو يتعلق بالفيكو مالتيفيكيشن. فيعني انتوا شفتوا كل حاجة through the microscope. طب المناظر الخارجية، يعني دلوقتي اكيد الجراح تبقى ماسكة الانسترومنتس ازاي، المسنود ازاي، الابروتش نفسه ازاي، الديبث بيرسبشن ازاي، هنحاول نوصل لكم very briefly في هذه البرزنتيشن. اول حاجة عندنا الانسيجن. هنا احنا السيرجن قاعد temporal. We have to take care of how you affix your hand. هنا fixing the hands by the fingers على cheekbone, and then moving very slowly. Okay. وده الangulation نفسه باين ازاي بتاع entry of the keratome. And then you get the viscoelastic. You have to take care very well of this step, because the cystotome movement is easy. We know how to do the cystotome, how to move it all around the anterior capsule. But moving to the rectus forceps, you have to know that you are going through a very small incision, and a large movement outside goes to a small movement inside. To move from right to left, you have to take care that you are pivoting. You are not disturbing the cornea, and you also have to make very efficient use of your movements. بالعربي نبصوا على اللي قدامكم. الحركة هنا كلها هو ليه بيطلع يخبي الفيديو. بصوا على الفيديو نفسه ماشي ازاي. هعيدلكوا تاني معلش. بصوا على الفيديو اللي هو through the microscope. في نفس الوقت بصوا على الموفمنتس بتاعت الفينجرز بتاعت السيرجن، وازاي ان هو only with the tips of the fingers is moving to and fro. He is not tilting. The movement is from the phalanges, is not from the wrist. And concentration is the rule for all of the surgery, but it's very special for this step. Look through here and look through the movements of the fingers. Because you are going to look at a surgeon in the learning phase right after this, and see how we can all fall into this error. Or beginners can fall into this error. Here. Note the movements. The microscope is okay, and the rexus is going circular, but the movements of the fingers, he is not moving from the fingers. He is moving from the wrist, and he is turning the forceps all over. Movements are not efficient, and this is a loss of time, loss of concentration, loss of work. This is Professor Ismail doing his rexus with his microforceps. There is no harm whatsoever to affix the forceps with the finger of the other hand. Sometimes it is necessary. You are the judge for yourself. Note here, this is the nucleus, this assembly of Dr. Ismail. Note that he is pivoting at the column, at the paracentesis, a very, very, very big movement outward to only move from a point to another next to it, right next to it. Pivoting, so the key word is pivoting at the what? Pivot. P-I-V-O-T. Do not forget this. Always keep it in mind. Now, this is a very important movement that you have to do to learn how to do the probe, because you do not want to occlude during your cortex, during your quadrant removal. So you have to be able to move the tip, your phaco needle, in this manner, to and fro, and to the sides, always again pivoting. Look at it again. The movements are again just from you're holding it like a pen, holding it properly, and then moving it through the wound to and fro. This creates flow, and this makes some turbulence and increases the followability of the lens. Here, from the superior position, Professor Ismail is again holding it properly and going through the wound. To go a little bit faster, I want to just show you some quick tip about my quick chop. Here it is. Let's start it. The tip has to do with the foot switch. So when you are rotating the lens, you should always rotate either in position 1, or if you are having continuous irrigation all the time, then okay, position 0, you remove all your foot from the foot switch. But rotation, when you rotate, it always has to do in position 1. When you are chopping, like here, you have to put your chopper not only perpendicular to the other. I actually don't do it, I put it on 60 degrees, I prefer it this way, but it has to be perpendicular vertically to the lens. So if the lens surface is like this, your chopper has to come directly perpendicular to it. Otherwise there will be misdirected forces. Rotation in position 1. Here I'm trying to unclog. As you can see, the vacuum is increasing. Try to move it a little bit, and it worked. The point with the irrigation aspiration is that you roll with your fingers, with the bimanual. Bimanual is the way to go. The coaxial is very dangerous, and the bimanual that the Professor Asaf told us about is the way to go. To control it and get the 2-3 clock hours, you actually, look here, you see, there was a 2-3 clock hour movement. This 2-3 clock hour movement was with the rolling of the fingers. This is how you do it. You affix, like the surgeon is fixing here, and all the movement is between your fingertips. Whether this be of a viscoelastic or, and this is also irrigation aspiration. This is a novel view, never seen before, oblique view of the anterior chamber. And you can here appreciate how you can see the fluid exiting through the side port as well. To know that the side port is always leaky. Last and most picturesque is the intraocular lens implantation. Note the angulation with which this surgeon is approaching the lens. He is directly down towards the capsule. This is Dr. Ismail, again doing the same angulation. Dr. Fathy Fauzi. He has a tip here that we might make use of now. The tip here is that he inserts a second instrument, to affix, to prevent the intraocular lens from shooting to the 6 o'clock position and opening the capsule. So it's a controlled injection. From this view, well, the next view, the next video is even more demonstrative of the point I want to show you. It will come right away. You can see from this, in this view, you can even see the edge of the anterior capsule. It is here, wow, but look at the lens when it's going, when it's being implanted. The same angulation, but watch out. Lens is almost at the back of the cornea. So you can never appreciate this from the top view, but you have to keep it in mind, and you have to always be careful because the lens is the most injurious to the endothelium. There are many more behind the scenes that have to do with the science, that have to do with more of the foot switch. I'll be available, and you can easily reach me by the email that Dr. Hayati instructed us to put, and sorry, it's going back here. It's Hazem Rashed, and either Hotmail or this one, the domain of the university that you have. Thank you very much. That's it.
announce بس صغير. ما تنسوش يا جماعه ان الريفراكتيف كورس هيبقى يوم 18 مش كده يا دكتور علي؟ ما تنسوش يا جماعه ان في لايف سيرجري هيبقى يوم 25 فبراير. لايف سيرجري هيبقى يوم 25 فبراير. اعتقد ان دي هتبقى حاجه مهمه كلنا لازم نحضرها. ما تنسوش الايفالويشن فورمز برضه ساعدونا شويه ان احنا نحاول نحسن الكورس. عارفين ان كل حاجه فيها ديفكتس، فاذا انتم شايفين في ديفكتس او عايزين امبروفمنت في اتجاه معين، الايفالويشن فورم وانتم خارجين دلوقتي اللي بتملوها تبعتوها للدكتوره هايدي عشان ده يساعدنا. الفيدباك ده بيهمنا جدا، نقدر نحدد اذا كان في حاجه ناقصه او في حاجه نقدر نعملها نزود الكورس نخليه احسن شويه صغيرين. ما تنسوش كمان الاتندنس اوف سيرتيفيكيت هيبقى مع الدكتوره هايدي والدكتوره نانسي. فهم 4 حاجات. ريفراكتيف كورس هيبقى يوم 18 فبراير، لايف سيرجري يوم 25 فبراير، ايفالويشن فورم ما تنسوهاش وانتم خارجين النهارده، واتندنس اوف سيرتيفيكيت يو شود اسك الدكتوره هايدي والدكتوره نانسي. يوم 25 نبقى موجود. 25 فبراير. شكرا، اسفين احنا اتاخرنا عليكم وطولنا عليكم النهارده.